about the type and the nature of the anemia, and the first one is microcytosis. Microcytosis means that the cells are too small, the red blood cells are too small. Their MCV is less than 80 femtoliters. This typically occurs when the hemoglobin is insufficient or abnormal, to your point on like iron deficiency. You'll see in iron deficiency, you're going to see these small cells. And here, they're hypochromic, so they don't have that redness. They're pale. You'll also see a microcytotic panel in thalassemia, and you'll also see it if you're not synthesizing erythropoietin, something like, kidney dysfunction. Macrocytosis are big cells where the MCV is greater than 100 femtoliters. These are often associated with nutritional deficiencies where you don't have enough folic acid or enough B12. Okay? And so the very first thing you do is, what's the hematocrit? The second thing you do, what's the size of the red blood cell? What's the MCV? Are they big or the volume? Are they big or are they small? The next thing you do, and I'm not speaking like I'm a clinician, Loretta, jump in. I'm just saying in terms of the overall reasoning, you're thinking about all these things, simultaneously. Other red blood cell indices are, then you start looking in the smear, how many reticulocytes are there? Now, reticulocytes are the most immature circulating red blood cells. They still might have a hint of the endoplasmic reticulum on them. And you count how many reticulocytes there are in that circulating pool. Generally, in a normal situation, it's 1% or less of the circulating pool are reticulocytes. If you have a high reticulocyte count and the person is anemic, that might suggest it's compensatory due to an increased erythropoietin, because that's what's stimulating the production of red cells. But you would have some assumptions that you'd need to make along with that. With that erythropoietin, you needed sufficient iron, you needed sufficient B12, folate, etc. If you have a high reticulocyte count and there's anemia, that could be an indicator of hemolytic anemia. Again, did you make them not well enough or did you break them too much? If your reticulocyte count is low and you're anemic, that would suggest that you've got a decreased red blood cell production. So the reticulocytes, along with the size, are very powerful indicators in helping you think about the anemia. Then there's another term, this is the first time you've seen it in today's talk, called the red cell distribution width, the RDW. It tells you, if you will, it's the standard deviation of all the sizes of the red blood cells. So there's variation, not all red cells are the same. The general normal standard deviation is somewhere between 11 and 15%. When you start increasing the variation in the red blood cell size, where now maybe it's 25%, all different sizes of red blood cells, that can occur in several forms of anemia, like iron deficiency, pernicious anemia, folate deficiency, thalassemia, and liver disease. So you're looking at the spread of the size of the MCVs. In this case, the width, but the size of the red blood cells. You're looking at the numbers of reticulocytes per the whole. You're looking at the size, the MCVs. And then you're not going to forget about the hemoglobin concentration and the MCHV. And from that, you can start to panel out some of the panels on anemia, the TIBC, etc. So this just tells us a little bit about the reticulocytes. They're generally released from the marrow. They circulate for 1 to 2 days and then they get mature. They have a little bit of RNA if you stain them. They're bigger than red cells, and again, they're normally 1%. So here's a reticulocyte on this smear, this one right here. This is a reticulocyte on this smear. Here's a mature red cell. Here's a mature red blood cell. It just shows you they haven't, achieved total maturity yet as an erythrocyte. So if you are anemic for whatever the reason, looking at the entire panel and trying to understand, and we'll talk about specific ones, the major issue is you've lessened your oxygen carrying capacity and your tissues could become hypoxic. Like everything, your body is smart. It tries to compensate for the tissue hypoxia largely by increasing your heart output. Your heart rate will go up with anemia. Your cardiac output generally goes up with anemia. Your stroke volume, depending upon the extent of the hypoxia, will increase to try to compensate for the anemia, to try to maintain flow and blood flow to vital organs, your brain, your heart, your kidney. So anemia will be met with a compensation right here. That's number one. Anemia will also be met with a compensation where it will change the affinity of hemoglobin to oxygen, number two. So things like 2,3-DPG will start to be produced and you'll unload at the tissues better, so the tissues aren't as hypoxic. And then number three, which you're always thinking about right now, is if you were anemic, your kidney sensing that relative hypoxia and it's driving out erythropoietin and you're going to try to make more red cells. So these are general characteristics of all kinds of anemia, not necessarily easy to pick out. Milder forms of anemia have much more subtle effects than extreme anemia. So in mild anemia, you may not have any clinical symptoms. And Loretta, please, I'm sure you see hundreds of patients every year with, no major anemia, but it's associated with cardiovascular, pulmonary disease, and what? Kidney disease. Mild to moderate anemia, person's fatigued, they're weak, stamina, a little bit more of a tachycardia. When they move, a little bit more shortness of breath. So now there are some symptoms that might be interrogated. And then in severe anemia, hypotension, vasoconstriction in some tissue beds. The two tissue beds that first to vasoconstrict with more severe anemia are your skin. So you have less, you don't want to dump it to your skin, you want to keep it going to your brain, to your heart, places that need it. The other place that is a very potent vasoconstrictor, again, kind of a Robin Hood phenomenon, shunting the blood out to where it might be needed, is the kidney. Now the kidney certainly needs blood, but the kidney gets a lot of blood flow, makes a lot of glomerular filtration, so it has a little bit to give, to have stolen from. So there's vasoconstriction in the skin vessels, there's vasoconstriction in the renal vessels, but in hypoxia, other places dilate. Hypoxia in general is a vasodilator. So this can change your pallor. Fast breathing rates, shortness of breath, fast heart stuff, transient murmurs, your papillary muscles in your heart might change. In worst case, it can induce chest pain and heart failure. In your skeletal muscles, you could have, claudication and you get cramps in your muscles, in your head, headaches, lightheadedness, faintness, ringing in your ears, that sort of things. So anemia has all kinds of associated symptomology with it. And now what we'll do here in this last couple of minutes, and I won't keep you the whole time, but we're going to at least